HOTT principles in traumatic cardiac arrest. Recent epidemiological data from the Trauma Audit and Research Network reports an incidence of 0.6% for cardiac arrest associated with trauma, where approximately 1 in 20 pre-hospital patients will survive. The main goal in a traumatic cardiac arrest resuscitation attempt is to rapidly and aggressively treat potential reversible causes prior to starting any advanced or basic life support procedures. Hypovolemia. Managed with external hemorrhage control. When it comes to limbs, use a CAT tourniquet. Apply it 5 centimeters above the injury site. Choose a single bone if possible. When tightening, don't stop until the bleeding stops. And then once applied, make sure you write down the time and date it was applied. Alternatively, if you cannot use a CAT tourniquet, you can put pressure and compression with a hemostatic agent dressing such as Celox. Usually used in torsos but can be used in other parts of the body. Keep packing the wound until the bleeding stops. Oxygenation. Oxygenate the patient to help treat hypoxia with a non-rebreather mask at 15 litres per minute. Tension pneumothorax. Place 2x16 gauge large bore cannulas on either side of the chest, second intercostal space above the third rib, mid-clavicular line, lateral if near the heart, to help release any air trapped in the pleural space. HOTT principles recommend addressing issues of tension pneumothorax prior to starting any chest compressions. Cardiac tamponade. Clinicians in the pre-hospital setting cannot do much for a patient in cardiac tamponade other than stabilising their ABCs and transporting them to the right place. The main goal is to reduce the time that the patient spends out in the field. Subscribe to the channel for more.